Walking pneumonia is caused by Mycoplasma pneumonia. It causes more than 2 million infections per year, and this year there's been a crazy outbreak, especially among children less than 5 years old. The problem is that it is pretty hard for pediatricians to diagnose and treat it because it usually doesn't occur in that age group. My name is Brandon Hunter. I'm a board-certified pediatrician and pediatric ICU doctor, and I'm going to unpack all of this for you today. Specifically, we're going to talk about what causes walking pneumonia in children, why is it so hard to diagnose, and then how do we treat it. Okay, so the CDC has said that Mycoplasma pneumonia cases have been on the rise this year. So let's look at this graph and see what they're talking about. So basically, this is the percent of pneumonia cases caused by Mycoplasma on the y-axis, and then the month and time of year on the x-axis. So we'll start off with some good news. You can see that the cases really spiked here in the end of July and early August, and they've started to downtrend, but kind of plateaued a little bit here in November. So what's important to focus on are the colors. So blue, orange, and green are the colors for pediatrics, but I especially want you to pay attention to hear the orange and the blue lines. And why are they important? Well, these are the youngest kids. So blue is kids 0 to 1 years of age, and orange is children 2 to 4 years of age. You can see starting on the left side of the graph that the green line was already a little bit higher. So this is 5 to 17-year-olds. And this is where pediatricians are kind of used to seeing walking pneumonia or Mycoplasma causing infections in this age group, much higher rate than the others. But what's interesting is in June or July, you can see that those blue and orange lines start to go up and they start to peak. And so what's really tough about these age groups is that as a pediatrician, when you're trained, it's just not your sort of first instinct to think about Mycoplasma in this age group, but it's much, much more common and thought of in those 5 to 17-year-olds. And so just to review real quick, what do we mean when we say pneumonia? So in the last videos, we talked about the different structures of the respiratory tract, but just to quickly run through it. So remember there's this structure called the larynx or the voice box. It sort of divides the upper respiratory tract from the lower respiratory tract. So if there's something infecting up here, you could have a common cold, an ear infection, or croup. And then down below, if those two big structures that branch off from the trachea get infected, they're called bronchi. You can have bronchitis. If you have the structures a little bit further distally towards the periphery of the lung, called bronchioles get infected, it's called bronchiolitis. And so what do we mean when we say pneumonia? Well, we mean it's when that infection gets past the bronchioles all the way into the lung tissue itself. And so remember, these are called alveoli. They're the fundamental units of the lungs, and they're where gas exchange happens. So just to unpack some quick terminology, because a lot of stuff gets thrown around, it can be confusing. For me, in general, if somebody says, hey, I think this kid has a pneumonia, like say I'm going into the intensive care unit and one of my colleagues signs out and says, we had an 18-month-old come in, they got very sick and we had to put them on the ventilator, I think they have a pneumonia. If that's all they say to me, what I usually think they mean is, oh, I think they have a typical bacterial pneumonia. So the next question for them is going to be, oh, well, what antibiotics did you put them on? But when we say pneumonia, what I just said is all it really means is that something causing an infection has gotten into the alveoli. So really, you can have anything cause a pneumonia. You could have a viral pneumonia. We sometimes see this with influenza, or you could have an RSV pneumonia rather than just bronchiolitis. You could have a fungal pneumonia from Candida or Aspergillus, not very common, usually with patients who are immunocompromised. You could have a typical bacterial pneumonia, say strep pneumoniae is pretty common, or Haemophilus influenza, or you can have an atypical bacterial pneumonia like we're talking about today. So what's the point of this aside? Well, it's just to say, look, if somebody says, hey, I think your child has pneumonia, what they're usually communicating, to me at least, is a bacterial pneumonia. But if they qualify it and say, hey, I think your child has an atypical pneumonia, or I think they have a walking pneumonia, or I think they have a viral pneumonia. Those are really critical qualifications because they're just saying, I think there's an infection in the lung tissue, but the response is going to be different based on what's causing that infection or what's causing that pneumonia. Okay, so that's what it is. Let's jump into why is it hard to diagnose. So there's a couple reasons, but let's just start off here. So the symptoms are often pretty mild. So it's called walking for a reason. Kids just don't look that bad. Maybe they're just walking around and have a lingering cough, maybe some low-grade fevers, something like that, but they're doing okay. And so it's not really sending any red flags up or putting people's antenna up. And not only that, but a lot of the symptoms really look like a viral illness. So things like cough, sometimes you have upper respiratory infection symptoms, low-grade fever. These could all be seen with viral illnesses as well. But then to make matters worse, I found this study from 2018, and you can see down below, viral co-infection occurred in 27% of cases. So this means that even if you have atypical pneumonia, you might also have a virus infecting the lungs, complicating issues and making it seem like it's a viral infection. This at least is showing typical symptoms and the time course they usually occur in. So the incubation period is quite long, 2 to 4 weeks. But when the clinical illness starts, you can see you've got headache, tiredness or malaise, fever, sore throat, cough. You often have sputum production, but not always. And then the dullness and rales is saying you often have abnormal breath sounds, but not always. And then similarly, with X-ray findings, they tend to occur earlier in the course. And so you can see on the right that there are certain things that tend to come up more frequently than others. So fever and cough are quite common, fatigue is common, shortness of breath. But when you start to go down a little bit further, and even when you get to shortness of breath, 1 in 3 patients won't really have that. And so there's nothing specific that just tells you, okay, this is mycoplasma for sure. This is not a virus. And so this is why it presents a diagnostic challenge. Kind of hinted at it on the last slide, but it is contagious. So this is an unusual thing about pneumonia in general. Usually typical bacterial pneumonia is not contagious in the same way a virus would be. Well, atypical pneumonia, this is another thing that makes it atypical or unusual. It's contagious, but it's not contagious in an easy way to spot, right? So it can take 2 to 4 weeks to develop symptoms after exposure. This is not the same story that we usually get when there's a virus, where it's like, oh, I had a cough and congestion. A couple days later, my daughter did. A couple days later, my wife did. And you can kind of just see it going person to person. This is a little bit unusual and makes it harder to identify. And then finally, the bacteria itself can linger in the respiratory tract for months, so it can cause some persistent symptoms in some patients. All right, so there's a couple common paths forward. I would say at the beginning, if you present to care in that first 3 to 5 days, it would not be unusual, especially in that newborn to 4-year-old age group, to do nothing, where pediatricians may reasonably say, I think this is a virus because they have cough, congestion, low-grade temperatures, and so let's just watch it for a couple days and see if it gets better. That could be quite reasonable. Some people may say, hey, this is 2024 and we had cases surging, and so I'm gonna go ahead and just treat empirically, which means, I can't say what the diagnosis is for sure, but because of those limitations, I'm gonna say, for this patient in front of me, I hear this on the lung exam, or this constellation of symptoms just makes me think it sounds more like mycoplasma, then that may cause them to just treat straight away. I will note that one thing that might push somebody from either treating straight away or just observing is how mild the symptoms are. So they're kind of listed here, but having fevers, but they're low grade, no real respiratory distress that the provider can see, normal skin tone, color, mental status, normal oxygen saturation. These are all times where it may be reasonable to continue monitoring and figure out what's going on. But if a provider chose to treat at this point, it would also be quite reasonable. So maybe somebody doesn't want to do nothing and they don't want to treat empirically. Well, getting more information is also a possibility. So one thing that a lot of people do is get a chest x-ray. Now this I think is a good idea, and it will definitely help you narrow in on do you have a pneumonia or not, because that will show up on x-ray in a kind of classic way. But we'll talk about some problems with it. So first, let's look at a normal chest x-ray to see what we're looking at. So this is a kind of grainy image, but it's a normal chest x-ray, and you can see basically the heart is here in the center. It's a little bit white. These 2 big black fields are the lung fields, and this is how you want them to look. So air should not stop x-rays from passing through the body, and so lungs that are healthy, they should be filled with air, shouldn't have a bunch of gunk in them. The x-ray should just pass through and they should appear black on the screen. So patients are normally facing towards us when they do these x-rays, and so the right lung is actually here on the left side of the screen, sitting on top of the liver here. The left lung is here on the right side of the screen, sitting on top of the spleen here. And then we've talked about the diaphragm before, but you can see how it's kind of dome-shaped here on both sides. And that's just a normal looking diaphragm. That's that muscle that overlies the liver and the spleen and helps do the majority of breathing when patients are healthy. Okay, so if a patient has mycoplasma pneumonia or an atypical walking pneumonia, you'll often have an x-ray that looks like this. And so you can see, so same thing that we were looking at before, but one difference is, the lungs up here at the top of the lungs, or say the apex of the lungs, they're pretty black. It seems like you can see through them, but even there, they have these kind of fine lucencies. And they get more prominent as you go down further, but they're just kind of white in these stringy-like patterns all over the lungs diffusely. And this is commonly seen with atypical or walking pneumonia. So this would be a classic presentation for it. And if I was in the outpatient setting and I got this x-ray, then I would say, yeah, this kind of confirms my suspicions. I'm probably gonna treat for an atypical pneumonia. But realize, I've listed some of the other ways that it can present on the right side of the screen. So you can actually have like a true consolidation, a lobar infiltrate, or effusions in a number of different cases. And these can make it tough to tell the difference between this walking pneumonia and a regular typical pneumonia. I'll just show an example because those terms shouldn't really mean anything, but this would be an example of a typical pneumonia where there's a lobar infiltrate. And so what you can see here is, and again, sorry for the grainy image, but the right lung is pretty clear. It really doesn't look too bad at all. The left lung is pretty good up here, but then when you look down on the bottom right of the screen, or on the bottom or the lower lobe of the left lung, it's just all whited out. And that's a lobar infiltrate. And so this x-ray would normally make you think you're dealing with a typical pneumonia, but in about a third of cases, atypical pneumonia or mycoplasma pneumonia can look this way as well. So what's the point of this? Getting a chest x-ray can be helpful, but even then, it can be non-diagnostic and not perfect for telling you how to treat a patient. So what might be the most specific way to go about testing? Well, if you actually just look to see, hey, is there DNA from this mycoplasma present in the respiratory secretions of the patient? Then you can say, all right, well, I have a patient who has respiratory symptoms and I know that they have mycoplasma in their respiratory tract. So now I feel pretty confident this is a mycoplasma pneumonia, no matter what the x-ray shows. This is actually the most common way that we'll test for mycoplasma if you go to the ER or get admitted to the hospital or the ICU. And the reason is that the labs, often on site in the hospitals, are able to run these PCR tests pretty quickly, where we can differentiate, hey, do they have RSV, influenza, or mycoplasma, or another respiratory pathogen pretty quickly. It can be really variable in the outpatient setting, where some clinics may have on-site testing available, but others might have to send it to other labs where the turnaround time won't be as good for the samples. Okay, all that to say, there's a lot of variability in management of this illness in the outpatient and in the inpatient setting. But what I think most people would do is likely listen to the clinical history, look at the physical exam, and especially if there was a patient, say, who had a viral illness, was getting better and now seems worse. In 2024, when we know there's an outbreak, I think a lot of people would just treat empirically. But why have I been making such a big deal about this? Okay, so why is getting the right diagnosis important? And I keep saying, oh, typical bacteria, atypical bacteria, what is that all about? Okay, the key thing to note is that the treatment for mycoplasma pneumonia is very different from the usual treatment of all the other kind of typical bacterial pneumonias that we're used to treating in pediatrics. And so what is it? So azithromycin, or Z-Pak, is essentially the treatment for mycoplasma pneumonia in kids. There are others that I've listed here, but really not important for you to know. What I do want to point out, and this is just from the outpatient pneumonia clinical guidelines from the Children's Hospital of Philadelphia, is that the first line therapy for most pneumonias in pediatrics is amoxicillin. So this treats typical bacteria like Streptococcus pneumoniae. It does not treat mycoplasma pneumonia. And so this is the problem. As a pediatric resident, and then even as a fellow, it's kind of drilled into your head to think like, hey, if a kid is younger and you have a typical pneumonia, amoxicillin is a good first-line therapy. And then if they're in the hospital, you give them ceftriaxone, but that also does not cover mycoplasma. And you can see here in their pathway, they even said, hey, consider diagnostic testing and treatment for atypical pneumonia. This is talking about mycoplasma in children over 5 years old with insidious onset of symptoms or failed treatment for typical pneumonia. And so again, just looping back to the very beginning, why is this all like a problem? Well, the problem is that it's the 0 to 4-year-old age group where these cases were spiking. And for me as a pediatrician, I'm just usually not thinking about that. And then when you compound that with the presentation often looking like a viral infection or not being that bad, it can be really difficult. So hopefully that made things more clear and not more confusing. But the overall goal was really just to let you know how pediatricians tend to think about pneumonia, viral illness, and then this walking pneumonia. And the goal is really to just help you advocate for your children when you say, man, things really aren't getting better. Hey, this cough, it sounds a lot worse to me, or they're just not going on the usual track. They've gotten viruses before and it's never progressed like this. That type of thing can actually be very helpful for sharing with your healthcare providers. So hopefully that was helpful, and we'll see you next time for more.